So this time, I'm going to talk about two-stage exchange. In full disclosure, Ian presented a wonderful one on single stage, and on Monday, I'll be doing a single stage exchange. So I believe in both one stage and two stage. These are my disclosures, none of them are which are relevant for this talk. So as we all know, PJI is a big problem. PJI can be high as 2% in hips and knees, it goes to 5%. It's a financial burden, long hospitalization, and you have more complications after surgery. The real question you want to ask is, if you have an infection, what do you want for yourself? What do you want for your patient? What do you want for your mother or father? Two-stage exchange is considered a gold standard in much of the world still. It has high infection control rates, successful eradication, especially for resistant organisms, and have longer follow-up and survivorship. But that can change over time as one stage is becoming more popular. Historically, it has better control rates than DARE and one stage, but again, time will tell where we go from here. So why is it a gold standard? It's a gold standard in most places except for Europe, where we've talked about EndoClinic really starting off with instituting this factor. And I'll say after doing one stage, the tissues are much nicer. But there's a real benefit to doing two stage, where you can actually do two debridements and make a difference. When should two-stage exchange be used? It should be used in patients who have PJI if they're septic, if they don't have soft tissue coverage, if they have resistant organisms, or if they've failed previous treatments, such as a one-stage or a DARE. Looking at the International Consensus Meeting, Remy did a great job introducing the International Consensus Meeting, and I'm going to cover some of the questions that are relevant to two-stage exchange. So, should operative treatment differ in patients with systemic sepsis in the setting of PJI? Looking at all the different studies, of which were all retrospective, they all recommended two-stage exchange. This had 79% agreement, which is pretty high. The idea is that it reduced bioburden and by removing the components. Now, looking at the type of infections that we have, we separate into acute and chronic. And it's really the chronic infections that the one we have to consider two-stage exchange. And these are the criteria that we utilize. So as we all know, two-stage exchange, you start with an infection, you take out the implants and put a spacer in, and you reconstruct at a later point in time. The principles are all about debridement. We talked about this in depth, is you have to clean everything out like it's tumor surgery. Make sure everything foreign is gone. For antibiotic spacer placement, I personally, for every one bag, place 2 grams of vancomycin and 2.4 grams of tobramycin. Now, I do change that depending on the organism. If the organism is fungal or TB, I would change it to a different antibiotic or antifungal. I do directed antibiotics for 6 weeks. And after hearing the speakers here, 2 weeks might be more appropriate, but we do 6 weeks because it's based on osteomyelitis treatments. And we reimplant if there's no sign of reinfection. So the question we want to ask ourselves is, how much do we have to take out when we're doing surgery? Is it safe to retain a stable cement mantle for later use in patients who are undergoing PJI? We saw a great presentation where we saw that you could actually take only part of the cement and re-cement if there's no infection. But if there's infection, should we get rid of everything? And based on retrospective studies, we understand that cement removal is technically demanding and it definitely increases patient morbidity. However, if you do retain it, some studies have shown it's highly successful, and other studies it's not successful at all. This is what literature shows when it comes to infection. It's completely opposite ends of the spectrum. So the recommendation from the International Consensus Meeting with limited data states that under strict conditions and following a meticulous surgical technique, a stable cement mantle in the femur may be left in place for later use. I do caution that personally I try to remove all the cement, and I think that's why the agreement was only 63% with up to 29% agreement, which is pretty high. When you place in a spacer, the idea is you want to have infection control, deliver local antibiotics, and protect and maintain the soft tissue. You want to maximize patients' postoperative function. So a question becomes, do you do static or dynamic? Again, these are articulating or non-articulating spacers, of which they both have similar rates of reinfection. So what's the benefit of using an articulating spacer? The idea is that you maintain the joint space better, So when you go back for surgery, you can reconstruct it easier. However, as you can see here, the spacers can dislocate and potentially lead to more bone loss. So we can look at Kali's principle of one stage as potentially beneficial because you never have to endure this. From a non-articulating side, you don't maintain the joint space as well. You do have infection eradication, and it is much cheaper. The hard part is you put something like this in here, it can migrate. So you have to be careful about bone erosion in these static spacers and in articulating spacers as well. So for articulating spacers, there's multiple different types. You can do cement here with metal inside. You can do pure cement, but it's not very strong, so I wouldn't encourage that. And there's also a version where you can use polyethylene and metal and use antibiotic cement on both sides. In the US, we use something called a Prostalac, and it's used in multiple different countries in different ways. Again, the antibiotics in the spacer had to have high concentration. You want it to last for 6 to 8 weeks after surgery, up to 3 months after surgery. When you choose your antibiotics, you have to make sure that they're thermally stable and in powder form, ideally, so you can put them in and then create it and mix it to the cement. So vancomycin, tobramycin, and gentamicin are probably the most commonly used antibiotics. The problem is you don't want to give too many antibiotics. Too many antibiotics can risk kidney injury. So again, for reimplantation, you want to reimplant when the wound is healed. But the problem is right now there are no good real markers for reimplantation. ESR, CRP can remain elevated throughout the course of a patient's infection treatment. Ideally, it should go below 50% or continue to trend downwards, but that's not always a reliable marker. Most of the times, I actually aspirate my patients and try to get fluid from them. But sometimes there are dry taps. There's no fluid inside there. But if you do get it, you want to make sure your synovial white fluid count is low, and you want to make sure that your patient is a surgical candidate. This is a study done out at Rush, where they looked at oral antibiotics to see if they reduced the rate of reinfection after two-stage exchange. So after the second stage, should you give oral antibiotics after surgery? So they randomized patients to get it and to not get it. And afterwards, this was showing a survivorship curve that if you give oral antibiotics for 3 months, the rate of reinfection decreases. So we actually stopped the study early because we thought it would be not a good idea to continue to give it to patients, to not give it to patients who had two-stage exchange and could become reinfected. So the limitations of two-stage, very similar to what Ian brought up, is that if you do a one-stage and do it very well, patients only have one surgery, less morbidity and less mortality. For two-stage, obviously there's more morbidity when you have 2 surgical procedures. You probably have a longer hospitalization or a combined longer hospitalization. It's more expensive. Being in the hospital twice costs more money. The only thing is not just the patient is affected, but the whole caregivers are affected, right? Everyone who takes care of the patient becomes affected by this. They have to take time off of work. They have to take care of the patient. They have to take them to visits. So it becomes a very big burden on people besides just the patient. And again, the idea with one stage is if you do one stage, there's no soft tissue contracture. There's not a lot of scar tissue. So when you go reconstruct the joint, it becomes a lot easier. The other problem, though, is when we look at two-stage exchange, we ask a lot about what is the success rate. And if you want to look at the true success rate based on an older definition of success, this is looking at no infection, no mechanical failure, and no reoperation, it's only 65%. So because of this, we embarked in the Musculoskeletal Infection Society on a new definition of success. What is the new definition that we can utilize to define success? And 1 year was our cutoff. So tier 1 is the best. Tier 1 is infection control with no continued antibiotic therapy. However, some patients take antibiotics for life. So tier 2 was infection control with patients on suppressive antibiotic therapy. Tier 3 is where we start separating the failure and success ones. So A is aseptic revision less than or equal to 1 year from the initiation of PJI treatment, meaning if the implant failed, but not due to infection, within 1 year, that's considered a failure. If it's greater than 1 year, that's not considered a failure. If you have a septic revision or you get infection again within 1 year, again, that's a failure. But if it's greater than a year, then it's not considered a failure. Amputation, resection, arthroplasty, or fusion were all considered failures. The most controversial one was retained spacers. Sometimes I put a spacer in and I want to keep it there. So I don't consider it a failure if the patient has a retained spacer. Some patients, though, the spacer breaks, things like that, if it's retained, then that's considered a failure. Finally, for death, if death is less than or equal to 1 year from PJI treatment, that's considered a failure. But if it's greater than a year, the assumption is that it's not due to PJI, so that's considered a non-failure. So we already touched on one-stage exchange, so I don't have to go into depth about it. It's not yet a gold standard in Asia and the US, but it is something that patients are learning more and more about and actually come into my office and say, I have an infection, can I get a one-stage? This is what the internet does. We get too much information from it. Again, the benefits is that there are still low reinfection rates. The key with one stage, it's normally done in centers that are very, very focused on it and are very good at it. Good debridements, brand new setup, clean instruments. It depends on the person doing the procedure. So not everyone can do a one stage. If you're interested in doing a one stage, I would recommend going to watch someone do a one stage procedure so you can do the same thing and have high success rates. There are limitations, though, in that you must use local antibiotic delivery at the time of surgery. In the past, we used Simulan, and it causes some culture-negative seromas. But with newer formulations and different types of local antibiotic delivery, such as intra-articular, I think the success rate will increase exponentially with one-stage arthroplasty. So to finally finish up towards the end, I also have to say that two-stage, I like it personally because there's a lot of benefits and a less reinfection rate, at least what I've experienced so far. Up to 95% infection control. Some studies go up to even 100%, but normally smaller series. The idea is that it's still considered a gold standard throughout the world. And the key, though, is when you deliver the antibiotics, they have to be specific to the organism. So ideally, you can still identify the organism. You can use it in culture-negative infections, but you don't have as good eradication of the infection. Don't forget to monitor your patients and remember to use the culture to detect reinfection. And in this room, I'd encourage you to develop markers for reinfection, so we know reimplantation, so we know when to go back in after doing a two-stage exchange. Thank you very much.